you either select them to put you to sleep or you don't get put to sleep. So that they're the only game in town. So this is an issue. Another issue that I think we're going to have to address is when these bills come due and how they're handled. I was talking to my pastor about this particular issue, and he said, Richard, one of the problems we have is that a patient will get out of the hospital and 12 to 14 months later, they get a bill with a little note attached to it, and it said if you don't pay it within X number of days, then we're going to turn it over to a collection agency. Well, there should be some requirements in there to expedite that process. We should not be waiting 12 to 14 months before we receive a bill from that we have to pay. Now, there is a state that I really like what they've done, and then I'll hush and let y'all make y'all's presentation, or anybody on the committee make a comment. I don't know if any of y'all have looked at Pennsylvania's law. It said it shall be unlawful for any healthcare practitioner or any primary health center, corporation, facility, institution, or any other entity that employs a healthcare practitioner to balance bill, period. So, if you provide any kind of service, you can't balance bill. So, I don't think we're at that point yet, but I do think that we are at the point that we need to take a look at this and develop a solution to it. And like I say, you know, House Bill 71 and Senate Bill 8, you know, I gave everybody on the committee, and I want to thank the committee for being here today and taking a look at this issue. We talked about it for an hour before we got over here. And we all know it's an issue, and we all know that we've got to come up with a solution. And, you know, there's so many different interests out there that I want to be sure that everyone understands that, you know, we expect everyone to come to the table trying to come up with a solution to the problem. You know, it's important. It's important for the citizens of Georgia that we come up with a solution to this issue. I've talked a lot, too much already, but next thing I want to do is thank the committee for agreeing to participate in this. Representative Shannon, Representative Hawkins, Representative Lunsford, and Lunsden, excuse me, and Representative Taylor for agreeing to participate in this, coming up with a solution to this problem. Does anyone on the committee have any comment that they would like to make prior to start hearing testimony or comments from the audience? And this is not a for or against. This is all a for, trying to come up with a solution to this particular issue. So, anybody want to make a comment? All right. Who's first on the list? I don't have the list. I got the. Oh, okay. I do have the list. Osmond, Ahip. Test the mic to be sure it's on, please, ma'am.
Is it on?
It's on. Go ahead.
Good morning, Chairman Smith and members of the committee. I just wanted to thank you for the opportunity to be part of this discussion today to address scenarios that consumers and insurers are facing and different actions that are being taken in the states to address the issue. My name is Mara Osman, and I represent America's Health Insurance Plans. AHIP is the national association whose members provide insurance coverage for healthcare and related services. Through these offerings, we improve and protect the health and financial security of consumers, families, businesses, communities, and the nation. We are committed to market-based solutions and private-public partnerships that improve the affordability, value, access, and well-being for consumers. We've been invited to speak here today on behalf of our member plans in Georgia, which include most, if not all, of the insurers offering health insurance here. And we're here because the focus of today's hearing, as Chairman Smith indicated, is an issue that is significant and that we're seeing nationwide. To begin, here are some key considerations. Hospitals, as inpatient or outpatient facilities, provide services to consumers, and consumers going to hospitals that participate in their health plans networks expect that the services that are provided during that stay or visit are going to be part of the participating provider services. Some hospital-based physicians are employees of the hospital, and some are not. Some are independent contractors that work at the hospital, but not for the hospital. In fact, as that trend increases, both hospitals and insurers are seeing that more and more hospital-based physicians are choosing to remain out of insurance networks. Out-of-network hospital providers are a key concern when core services are delivered during a stay or visit by out-of-network providers. For example, by radiologists who read x-rays, scans, and other tests, by pathologists who interpret lab results, and by anesthesiologists or even ER doctors. These situations, as you indicated, represent most of the surprise billing cases that we're seeing nationwide, because so often when a patient arrives at the hospital, they're not in any condition to shop around to assure that all the services they're going to get as part of their treatment is going to be from a provider who's part of their network. And the majority of the time, the patients don't even realize that certain services are being provided as part of their treatment. Health insurers contract with facilities, physicians, and other professional providers in order to assure consumers have access to coverage for more affordable health care and for protection from the unknown costs of balanced billing. And it's important to consumers because, as you indicated earlier, the costs of balanced billing by out-of-network providers can be unpredictable, and they can sometimes be very extreme. AHIP actually released a report in October of 2015 that was entitled Charges Billed by Out-of-Network Providers and Their Implications for Affordability. It reviewed billed charges for 100 procedures using a national database of charges from Fair Health's National Private Insurance Claims Database, which is a vendor. The report examined out-of-network billed charges, and here's just a few local examples in Georgia. So in Georgia, patients that underwent a knee arthroscopy or surgery saw charges averaging more than 500% of the Medicare fee for the same procedure. Some patients
Now, you reference Medicare.
Yes, sir.
So you said it's 500% of Medicare.
Yes.
Why did you, so that everybody here can understand, and especially the viewing audience, why did you reference Medicare?
Medicare is often, the Medicare fee for different procedures, different CPT codes, is often viewed as a benchmark to get an idea of what is appropriate payment for different procedures. So insurance companies, different government programs at the state and federal level all look to the Medicare fee as some sort of measure. So there's other examples in Georgia as well as the knee arthroscopy. For example, for emergency care, we saw patients in Georgia that saw excess charges averaging more than 600% of the Medicare fee. Other patients who underwent a brain MRI incurred charges averaging more than 800% of the Medicare fee. And the final example would be charges for cervical and thoracic spinal injections averaged more than 1,000% of the Medicare fee for the same procedure. And we'd be happy to make the report available. It lists an entire page of examples of what patients in Georgia paid as compared to the Medicare fee for the same service. The Fair Health data that we used in this AHIP report was from a custom data extract. We used raw Fair Health data, including their extreme outlier data, because Fair Health usually excludes these extreme outliers in their own benchmark modules. The reason that we use the raw data with those extreme outliers because it really demonstrates the actual range of billed charges that health plans receive. But whether it's with the outliers or without the outliers, the data shows a very wide variation of billed charges as compared to the Medicare reimbursement. The results of this study really underscore the importance of the need for consumer protections and a consumer disclosure if there are out-of-network providers operating in a network facility. Consumers and employer groups benefit if hospitals and other facilities engage in good faith efforts to ensure that their hospital-based providers contract with the same networks that the hospitals contract with. This would reduce and even prevent the problem of surprise bills that are sent to consumers after discharge, such as the one you mentioned, Chairman Smith. Insurers depend on providers and other stakeholders to help protect consumers in these situations and share the common interest of making coverage more affordable and available to consumers. It's really a multifaceted problem that requires the involvement of multiple stakeholders to resolve it. We would not support, however, any solution that would require insurers to pay out-of-network reimbursement based on a methodology that uses billed charges as a criterion, because as indicated, this means that the payment amounts would have no guardrails and no reasonable parameters, since the providers can charge whatever fee they choose. It would be harmful to the overall health system, to hospitals, to consumers when premiums go up, and would provide the wrong incentive to those providers to not negotiate on charges or contract with hospitals or insurers. As you indicated, when the Georgia legislative session adjourned this year, the two bills that addressed out-of-network reimbursement took two differing approaches to benchmark payment for non-contracted providers. The bills, as they stood at the end of the session, one incorporated billed charges and the other reflected what the market is actually paying. The out-of-network balance billing issues and these costs that are facing patients and health plans and healthcare providers in Georgia are not unique and require a thoughtful and balanced approach. We believe that the balanced approach would accomplish these three goals. One, it would protect patients from bills they're not responsible for paying. Two, it would provide for fair and reasonable payment to non-contracted providers. And three, it would provide for a dispute process when providers feel they have not been accurately or adequately paid. State approaches could begin to address this issue by focusing on hospital-based non-contracting providers. The out-of-network, hospital-based providers' contract status should be disclosed to consumers. Providing more disclosure and education in advance to the patient when they're going to use a facility will help them make better decisions. States can consider how to protect the consumers, and here are three options. First, a balanced billing prohibition, as you just mentioned. Through statute or regulation, provide options to out-of-network providers. So, for example, out-of-network providers can accept assignment of benefits from the consumer for the services supplied by the provider, and the provider would agree not to balance bill the patient. The provider can then get a prompt payment of an in-network provider payment amount from the health plan, and the consumer would be responsible for their co-payments. And again here, the provider would not balance bill the patient. If the out-of-network provider chooses not to accept the assignment of benefits, they should not be able to bill the patient in that circumstance either, but they could receive the patient's co-payment and a charge amount that's aligned with a benchmark payment amount set by the state. It's not unprecedented to do this. 14 states at least have explicit prohibitions preventing non-contracted providers from balance billing enrollees in certain circumstances, and that's not even inclusive of the bills that have passed this year during this legislative session. And 33 states prohibit contracted providers from balance billing. Another way to protect consumers is through advance notice and consent to out-of-network charges and care. This would require providers to supply notice to payment to patients, and then signature received from the patient to ensure understanding before a provider actually performs the service. The notice would indicate that the in-hospital provider may not be a participating provider with the patient's plan, and that the patient might be responsible for any amount the provider decides to bill the patient over the amount that the health insurance plan reimburses the provider for the covered service. A third approach to protect consumers would be regulatory oversight for unfair billing patterns. So here, the state would review patterns of balance billing or charges, and when consumer protections have been enacted, and make a determination of whether there are excessive or unfair billing patterns that could prompt action by a state regulatory agency with a jurisdiction. With respect to fair and reasonable payment, states can consider benchmarks to payment for non-contracted providers, such as average contract rates or a percentage of the Medicare rate. And for emergency services, the rate of payment to hospital-based non-contracting providers should be the greater of these three possible amounts, excluding any consumer co-payments and co-insurance. So those three would be the greater of the amount negotiated with an in-network provider for emergency services furnished, The amount for the emergency service calculated using the same method that the plan usually uses to determine the usual, customary, and reasonable payments for out-of-network services, or the amount that would be paid under Medicare. States could, and many have considered, also establishing a binding independent dispute resolution process for providers and plans to resolve disagreements in these situations, and it should be a process that takes consumers out of the middle. There's various models that are being considered across the states and adopted. So here's just a litany of some examples of what other states have been doing to address this issue. Texas had previously enacted some statutes that established a mediation process for out-of-network physician payment dispute resolution. During this year's session, a bill was passed that expanded the list of providers subject to mediation to all facility-based providers and all emergency care providers. In Illinois and Florida, the states tried to institute a provider dispute process, and it's had some limited and varied success. Last year, Florida expanded that law to also apply to PPOs. The 2016 Florida law also did some other things. It prohibited balance billing. It set forth disclosure requirements. It establishes reimbursement to out-of-network providers of covered emergency and non-emergency services as the lesser of the provider's charges, the usual and customary provider charges for a similar service in that community, or the charge mutually agreed to by the health plan and provider within 60 days of the submittal of a claim. New York's law, that was first implemented in 2015, requires a provider dispute process through binding arbitration for surprise bills, and this year, Arizona enacted legislation that establishes dispute resolution for surprise bills and requires arbitration. In New Jersey, they had a requirement to have insurers pay bill charges in these scenarios, but right now the state's hard at work to develop legislation to address that unsustainable approach. It's notable that New Jersey has some of the highest health insurance premiums in the country, in part due to this problem. So that's why they're trying to work it out there. In 2016, Connecticut enacted a bill that requires carriers to pay out-of-network services at an in-network rate under the plan as payment in full, unless the carrier and provider agree otherwise. The bill also defines a surprise bill for non-emergency services by an out-of-network provider at an in-network facility when the insured did not knowingly elect to receive the services from the out-of-network provider. Two further examples, and then I'll move on. One would be Delaware. This last year, Delaware enacted a law that requires contracting status notification by the provider and sets up an arbitration process for disputes when notification is not provided. If the providers fail to give contracting status notification, then they're prohibited from balance billing. And in California last year, a law passed that bans balance billing by out-of-network facility-based providers who deliver non-emergency care and establishes a benchmark payment to these providers at the greater of 125% of the Medicare rate or average contract rates. The law also requires state agencies to develop an independent dispute resolution process to address billing disputes. These models are all an attempt to resolve the issues and indicate that the issue is extremely important, and hospitals too are concerned about their ability to manage these provider scenarios. In 2017, at least 29 states addressed the issue of surprise billing, and more will continue to consider this legislation as their legislative sessions this year wrap up. The National Association of Insurance Commissioners, or NAIC, has also focused on the issue, and in November of 2015, they adopted by unanimous consent update to the NAIC model on network adequacy, which contains an approach to address the issue of out-of-network charges, and it was developed in coordination with stakeholders across the entire healthcare industry. It can be found in Section 7 of the Model Act, and it's entitled Requirements for Participating Facility Providers with Out-of-Network Facility-Based Providers, and here's some of the items that it includes. A notice provision that is required of both the participating facility and the out-of-network providers working at that facility to disclose that health professionals involved in the care delivered at the hospital might not be contracted providers of the plan. A requirement that if an out-of-network facility provider bills a patient, the provider must notify the patient of their right to copays and co-sharing as if they were a network, to choose to pay the bill, or if the amount's over $500, send the bill to their health care plan for processing using a benchmark payment, to request a provider mediation process, or to exercise their right to appeals available in the state. Also in the NAIC section, there's a limitation on balance billing the patient. There's a process where the states establish a benchmark for insurer payments, and there's a provider mediation process that's established in accordance with the national mediation standards, and of course, an enforcement provision. This language of the NAIC model was supported by consumer groups, insurers, and regulators across the country. And the American Hospital Association supported the new language in a comment letter stating that the AHA supports the proposed revisions, which would create a balanced solution among providers, health plans, and hospitals to better protect consumers from unexpected bills. And we agree.
Question.
Yes, sir.
Did the providers endorse this? You said the insurance, consumers, hospitals. Did the providers endorse NAIC's model?
Yes, the AMA and providers were part of the ongoing conversation. It was a very intense dialogue and working process that took place over the course of about a year and a half, where there were constant phone calls and meetings with all the stakeholders, including medical providers, coming to the table to try to find a solution. In closing, I would just like to say thank you again for the opportunity to be here to discuss these issues, and that as you address these issues in Georgia, it will be critical to identify what the key problem is in Georgia, how widespread it is, and to develop solutions to prevent the problem and handle it so that consumers are not put in the middle of payment disputes. Any solutions, we would have to carefully provide protection for consumers without increasing care costs and avoid creating disincentives for providers to participate in networks, avoid unreasonable paperwork for providers and insurance, and avoid one-sided solutions. Thank you again for the opportunity to speak here today. I'm happy to take further questions.
Question. You reference fair health numerous times. Has any studies been done to determine how much premiums would increase if the fair health model was implemented? Because if fair health is bill charges, it's just like going to a car dealership and paying what's on the sticker on everything. Whatever the doctor or provider decides to charge, that's what fair health numbers are. Because currently, we have people who are already paying $1,800, $2,000 a month for health insurance premiums. How much would this increase premiums if fair health was implemented?
I'm not aware of any formal studies on that topic, but if you just take it logically, the premiums would undoubtedly increase because you have a cost factor that's unknown. And there's no guardrails on what bill charges can be. They could be 500% over Medicare rate for the same service, or $1,000 over the Medicare rate, and it would change and vary with the provider and with the location. So there really would be no reasonable parameter on that number.
Okay, well, with those, I understand there are some states that are using fair health. Is that true?
Not to my knowledge.
Was Connecticut one of them?
We've been tracking what the different states are doing. No state law identifies fair health in their law. Typically, states that we're aware of don't like to name a particular vendor. I believe there is one state law, either New York or Connecticut, that describes a nonprofit entity, and fair health would fit that description. However, they're not specifically identified.
Okay, now, under the fair health scenario, because my feeling is under fair health, premiums will go up, and then what would be the incentive for a provider to get in any network if they're being paid at the fair health rate?
Fair health is a database of bill charges. So there's no set rate. It's whatever. The rate would be whatever the provider wants to charge. That being said, that would be a disincentive for a provider to join a network, because then he would be circumscribed by what the market says one should be paid or what Medicare says one should be paid for a particular service, rather that by not contracting with a network, they could charge whatever they want.
Okay. Number 19, Representative Hawkins.
Very informative testimony there. Would you provide us a written form of your testimony?
Yes, sir.
That'd be great. I have a few questions, just try to get you to help me understand. You said quite a bit this morning. You said most providers choose not to be in networks. Is there a reason for that?
There's a trend that we've recognized across the country where more and more providers are choosing to sometimes remain out of a network because then they have the ability to charge whatever fee they choose rather than to accept average contract rates or other set payments.
How do you determine the fee, the insurance type company? How do you determine what the fee should be for an in-network provider?
I'll speak generally because we have a lot of different members, and so I would suggest that to them. But typically a plan will have a certain type of formula that looks at usual, customary, and reasonable charges in a certain geographic area for a certain service to get a realistic parameter on what the market is paying for a certain service. So rather than pick a number out of the sky, they're trying to get a sense of what the market is paying.
So you're basing your in-network payment on average fee?
I'm just describing one of the methodologies that plans uses. They also contract and negotiate with providers in order to get rates that will be more beneficial to the consumers that are part of that health plan.
So below average then?
I would not say
Probably.
that.
Okay. How about Medicare? Who determines Medicare fees?
That would be your favorite federal government.
Yeah. Okay. How often do they review those fees and update them? Do you know?
I can get you further information on that in terms of how Medicare sets the fee and goes about their methodology, but I don't have the specifics here with me today.
Would you consider that Medicare is also an average fee?
It is a benchmark that is used in industry to get a sense of what a reasonable fee would be.
But that's not an average fee. That's just a benchmark that someone on the federal level chooses to use, correct?
It's a benchmark that's set out in the Medicare program.
But not average fee. Because what I hear from my physicians is it's sometimes 60% of their fee, sometimes less.
Well, I'm not sure how one would describe average fee. So Medicare rate for a procedure would be one type of benchmark measure, parameter for a fee. Average fee would be looking at a whole set of fees across a population or across a program for a certain procedure and then finding out what the average is. So for example, if you looked at billed charges, just use billed charges as the environment of fees you're looking at and you wanted to find the average, that's one thing that is in our report on billed charges, and you find that on average in a certain state for a knee arthroscopy, providers are on average charging 500% more than what the Medicare rate is.
Well, it sounds to me like your companies, insurance companies, are pretty good at collating information and keeping track with all that. So do all the insurance companies pay the same fee for the same code?
Those are private negotiations between the health plans and their contracted network of providers because the health plans are all designing products. And
So
the
no,
product
that-
is the health plan and the health plan network.
Okay,
And
so
you're
it's
all
not
deciding.
the same fee. Okay. All right. I just have a few more questions, and I'll hush up. How about narrow networks? I hear from my physician friends and from my hospital and from I'm a dentist, and from some of my dental folks that they encounter narrow networks. Can you speak to that just a little bit?
Certainly. I believe what you're speaking to is high-value networks. So to take a step back, health plans, when they design products, health insurance products, plans for consumers to choose from, want to give consumers a variety of choices. Some consumers like to buy an insurance plan that has a broad network. Other consumers are finding it attractive to buy a plan that has a tailored high-value network. What that means is that the network has been developed based on selecting providers who have a track record of providing high-quality, cost-efficient care. And that way, the health care consumer is buying a product where they know they're going to get the best value for their healthcare dollar.
Well, see, we have a situation at Northeast Georgia and at South Campus where we have physicians that are in network at the Northeast Georgia, but the South Campus, which is Brownston, they're out of network for the same insurance company. and it's not by their choice. It's just not allowed to be in network. So I just find that sort of puzzling and confusing. And let me ask one last question. Am I okay,
Yeah,
or
go
should I
ahead,
stop?
go ahead.
Okay. Why is the in-network and out-network such a big difference in fees? I mean, it sounds like if someone's out of network, you pay them much less, or in some policies, you don't pay them at all. Is that correct?
I'm not familiar with that.
You're not familiar? So if you're out of network, the insurance company will pay you whatever you pay in-network providers?
It depends on the circumstance. If it's an emergency service, typically a plan will pay the in-network amount for that emergency service if it's supplied by an out-of-network provider in an emergency situation, as I believe the testimony spoke to.
So that covers all physicians in the hospital too? So it's, I mean, if you're in the emergency room or outside of the emergency room, a physician, attending physician in the hospital, if they're not in network, they get paid in network fees, and then they balance bill the difference. Is that what we're seeing here, or are they just not paid anything and they're billing the patient the entire fee?
I'm not sure that if I'm following the question, but basically if a patient arrives at a hospital in an emergency situation and they're seen by a number of providers on their care team, some of whom may be in network and some who may be out of network, often in an emergency situation, the providers are paid what the in-network amount would have been for that, be for that emergency service.
Okay.
And to get to your other concern earlier, while I can't speak to the particular situation in that community, I can say that when health plans develop networks, they do so in turn with the eye towards developing robust, healthy networks that meet certain independent accreditation standards that they have to meet in order to get accredited. So they're very careful in building their networks and making sure that all their providers are credentialed appropriately.
Well, you know, the situation sometimes is that day two, services are still being provided, surgeries, and that may not be considered emergency at that time. You know, they've come in and they are found to have a bleeder, they have kidney damage, whatever it may be, and the surgery's done 2-3 days later, so it's almost like a non-emergent situation. We have time, you know, to figure out who's in network and who's not, and that's important to the patient because we do want to help our patients. We you know, just cannot have patients not even have an understanding of what they owe, or a year later get a bill that almost puts them out of their home. And so in that vein of statement, you seem to look to the providers or the hospitals to tell the patient who's in and out, but the patient has a contract with the insurance company. You know who your providers are. Wouldn't it be much beneficial for the patient to contact you, or you're someone from the insurance company to contact them or their family and say, these are the providers, these are the folks that will take care of your mom, you know, on the agreed amount?
To support your point, disclosure is a good solution and a good approach to addressing the issue. One of the avenues that is being taken by many states, and it's a shared responsibility among the hospital, the provider, and the plans to address these issues. Plans typically have and provide patients with a list of a provider directory, whether online or in print, so that patients can see who, and they can call to see who's in their networks. We also see that many states and the NAIC are also making it incumbent upon hospitals and providers to disclose their contracting status at the site. So when the patient arrives at a facility, they can see if they're participating with X company or B company. And we're finding that to be a helpful solution.
So that's the primary way it's done, though, is that the hospital or the provider provides that information rather than the insurance company's contracted for the health care of that patient?
The insurance companies are providing information on who their contracted providers are, and many of the solutions that are being put forth and adopted in the states are directing also that hospitals and providers and facilities also disclose their contract status.
Thank you.
So what you're saying is that I can get on the internet, or if I'm not internet savvy, which I'm not, the insurance company would provide me a paper sheet of doctors who are providers who are in network in my community.
Yes, you can often call your insurance company and ask at this facility who are the contracted providers, or is this person in my network, and you can find it online as well in a timely fashion.
Well, let me ask you one more question. How soon do you know that that patient's in the hospital? Once they enter the hospital and codes are being put into the computer, are you receiving, I mean, is the insurance company aware that that's going on?
I'm not in operations, but I would assume when the claim is submitted or when the patient contacts the health plan is when the health plan knows that
Right.
they're in the hospital.
I would think so. So that may be an opportune time for the insurance carrier to go ahead and send the information to the hospital, to the patient. These are the providers on the list, and have
It
them.
may be too late then, because if they've already had the procedure done and
Well, I'm talking about as soon as they're coming in. I mean, there's a period of time when they do a diagnosis, I hope.
Yeah.
Yeah, it's a difficult.
Yeah.
So I'm just trying to find a way that patients know, or their families know, who's in our network,
Right.
rather than relying on a hospital who they can keep up with 800 docs, who's on one day and who may not be on the next, because it's not a calendar year that matches for every company every day.
It's also
That's why I think patients are getting, hurt and confused, is no one's really got the real information or accurate, up-to-date information of who's in and who's out.
Well, I know when I talked to the admitting person, I asked them, can you provide me a list, or could you provide me a list of everybody who's involved in my procedure, those who are in network and those who are not, so that if they're not in network, I will know if I can anticipate a surprise bill.
And that's probably going to be the best way, what you just described.
Mhm.
It's for the patient, the family to ask.
But I
Give
think
me a list.
transparency on this thing is gonna have to be critical.
yeah. Oh, I agree.
Now,
I agree with
the
you.
question comes up, what happens if you're in a severe automobile, I'm sorry, I'm taking your time. What happens if you're in a severe automobile wreck and you go to an emergency room and it's just you, no family members there, the ambulance took you there, and you're on death's bed? What happens then? Because a lot of your emergency room physicians are contracted with the hospital also, and there's no way for transparency because you don't even know what hospital you're in, let alone who your doctor is.
We don't know whether you have insurance or not.
That's right.
I've done dental. I was on staff at our hospital. Patient comes in, we don't know whether you have insurance or not. All we care about is just making sure that you're going to make it through.
Yeah.
No questions in the back with the physicians are asked.
Yeah.
I mean, we
But
don't ask those questions.
a good part of the time, your emergency room are contract doctors, not employees, and they may
No,
or
no.
may not be in that insurance network. And for those who are not in the insurance network, that's where the surprise bill comes.
Right.
Okay, Representative Taylor.
Thank you, Mr. Chairman. Just a quick follow-up. The procedure when somebody is admitted to a hospital, they're usually connected with what's a case manager or a pre-cert, and their job is to find out if you're eligible for coverage. And it's very difficult for an insurance carrier to take on the liability of referring you to one doctor or another. And at that point in time, when they make that first call, they're finding out eligibility for that patient. They can't really say, well, wait a minute, you've got this doctor, we think you ought to see our doctor. I mean, you're crossing some pretty tough lines there. But again, that's something to be addressed, but the first process the carrier doesn't know directly. It goes into a case management company first, or the provider division within the carrier to know that, looking for eligibility. So it would be a delay before you could start the treatment all over again with a new doctor, but that's another thing. I really wanted to thank you for your presentation today. We are all looking for an equitable solution to help the citizens of Georgia, which are the consumers of this health care, and it is a problem. My concern, and I wondered if you had any data, if it shows up any different in rural versus metropolitan communities. I represent a very rural district, and many times we just have problems having doctors at all. And is it bigger in metropolitan areas?
I can follow up with you and provide you a full copy of the report that would have the geographic distribution of where we're seeing the bill charges issues. That might get at your problem about the geographic distribution.
Okay. Thank you. And I wanted to also ask for a copy of your information because it is very good. And looking at this comparison, as we go forward as a committee here and next year facing legislation, I think it would be wise to have this type of data and help us to make this tough decision. And I also am a border district. I have folks that go to Florida or to Alabama, and we can't always know what is best for them, and they go in and out of networks because of the difference crossing into states. Another part that this is not even going to address are ERISA plans. This really zeroes in on insurance policies. We don't have control over ERISA plans. Is there any way you see to help those self-funded or ERISA plans? Because this is outside of it, unless you are making it directly for PPO networks that are rental networks or throughout carriers. If a self-funded plan is going to rent a network, then it would be applicable. Is there any other way to tie it to them?
There's a conversation that's been going on at the federal level on this issue, and I can circle back with you about where that conversation has gone.
Thank you. I would appreciate that. Thank you. And again, I thought you had great information. I appreciate your sharing with us.
Thank you.
Representative Shannon.
Yes, I appreciate you coming today, and I appreciate the information that you've given us today. I have a question for you. I wanted to know if you could provide some more, I don't know if you could speak to it right now, or if it's something you need to follow up with, but more information on the number of doctors that are working, doing independent contracting in hospitals, because I know that that is a rising trend, and I'd like to see what the numbers are on that. We've talked a lot about disclosure. That would do a lot to help the problem, but it does not completely solve the problem. Even not just speaking about emergencies, sometimes you have procedures where you have 3 specialists involved, and although doctors do everything they can to make all of their scheduled procedures, if one falls out, the hospital will do what it can to make sure that that operation still happens that day. And so I know that that is one of the ways that contributes to this problem of patients getting a surprise bill. So for example, if you have a patient who has had some internal bleeding, but it's not massive, it's something that needs to be corrected, you may have a GI doctor there to fix that issue, but if the originally planned anesthesiologist, for whatever reason, can't show up that day, the patient still needs the surgery, the operation, but that is a situation that could create a balanced billing, because they'll get whatever anesthesiologist they can to come in and handle that. So can you just provide some, I don't know if you can speak now, but just more information on the rising numbers of doctors that are, not actually employees within these hospitals? Because I know that even happens even with primary care doctors, and it's very confusing for patients. You physically see a doctor's office within a hospital, but they don't actually work for the hospital.
Well, I can circle back and address the trend that we're seeing in terms of specialty providers not contracting with being independent contractors at hospitals. When it comes to PCPs, that's not, a Consumer Reports article actually just even said this in January. That's not one of the groups or areas where we're seeing the most surprise bills. We're mostly seeing it with the hospital-based non-contracting providers. So I'll circle back with what information I can find on that more specifically.
Oh, sure. Not for primary care. I'm just making the point that in general, it's a trend that people are seeing, and it's confusing because, like you said, of course, for a primary care doctor, you wouldn't see this contributing to surprise billing because in advance you can select your primary care doctor. It's not an emergency. You know if the person's in network. But I'm just making the point that there are lots of doctors that are floating around within hospitals that are independent contractors, but to the average patient, it just looks like you assume they're part of the network because you're, the original doctor that you moved forward with was in your network. Mm-hmm.
Certainly.
Any more? Okay. All right. One question, and I don't see MAG on here, but I was going to ask them because Representative Hawkins referenced that on Medicare, sometimes the Medicare cost is 60% of the actual cost. Is there any way that we could get some generic data, because I don't want to identify any particular doctor, of how their cost is determined? Because we're constantly asking the insurance companies how you determine what the premium is, how a physician would determine what their cost is.
So the question would be, how does the physician determine what the cost is for
'Cause
them to provide the care?
you'd referenced knee surgery,
Mhm.
or I don't remember what you said, $50,000 or whatever it is. Excuse me, but how did that number come up?
The knee arthroscopy
Mhm.
example?
Yeah, how did that number from the physician side come up? What goes into making that determination?
That's an unknown. That's a black box. What
Mhm.
each provider decides to use as a calculation to determine their fee, absent of other parameters.
Okay, because, we're asked on how insurance company determines what they're going to pay. Well, how does a physician come up with, determine what they're going to charge?
And I think in the hospital context, the representative could probably speak to the manner in which a bill is set, because if you've got care delivered in a hospital, there's different factors that come into play, such as use of the MRI machine, correct?
Okay.
I'll address that a little bit. There's several factors that come into what a provider has the right. It's a free market. They set their price and their fee. Sometimes it's based on the market, what the other physicians are charging. They include rent and overhead. If you're in a high rent district, you're going to have to charge more to cover your cost of your liability insurance. There are so many factors that each one puts into it. On the other side of that, and I'm seeing more of this, is outcomes. We now are able to, and are gathering data to see what the outcomes are of different providers. If you are with a provider that is seeing great outcomes, they don't have infections, they don't have complications on the primary basis or internist. If your patients stay on their medications, they come in annually, they do the preventive, you're doing a good job. And the carriers are actually boosting what they reimburse you. And that will have an effect on when they set their bills again. They're going to say, I am more valuable because I have better outcomes. So there are a lot of factors that are today changing how doctors determine what they're going to charge. Hope that helped.
Can I speak to that? Yeah, and I'll tell you, if I can choose my patients, I will choose young patients without diabetes, and I can guarantee you my outcomes will go through the roof. But I'm 66 years old, and I treat a lot of folks my age, and they do have diabetes, and they have heart problems. They have a lot of other things, so sometimes our outcomes are not near as good because we're working with a fragile individual. I think we got to be careful in healthcare is that we don't get to a situation where patients are chosen because the outcome will be better, but rather we choose patients that need our help, and they choose us because they have confidence in us, and when we talk to them, it's an eyeball to eyeball and not facing a computer and they see the back of our heads.
Okay.
I agree with that, but I will tell you, for example, coming home from session this year, my doctor was on my door, on my phone, in my email. It's time for your physical. They made sure I came in and did it. I still have those same things. I haven't lost enough weight. I don't get enough exercise, but they're making the effort. And I think that's part of what they're doing. You can't judge him on the outcome. You're right. He would do much better off with a 25-year-old than with me. But he is doing everything to prompt me to do the right things, and it does show. I think that's where we're going.
Are y'all finished with your debate here?
I'm just smiling now. Will's the grandson.
Okay. All right. Okay. I had another question, but I'm not going to ask it. That's okay. I don't forget. Once you reach a certain age, parts of you don't work. My brain's one of them. Okay. Thank you, ma'am.
Thank you, Chairman.
And
Thank
we'll
you,
wait on your copy of your presentation, and because this is the first of several that we're going to have in order to get this issue resolved by hopefully next session.
Thank you, sir. Thank you,
Thank you.
members.
Okay, next is, his handwriting's about like mine. Chuck Friedman. Identify yourself and who you with, please, sir.
Yes, sir, and thank you, and I take that handwriting reference as a great compliment.
No, you
Indeed.
don't either.
Hi, I'm Legislative Liaison with Georgia State Retirees Association, which is, as it sounds, composed of retired state employees, also active state employees and educators. I'd like to thank you, Mr. Chairman, and also members of the committee for letting me come before you today. It's a great pleasure to speak to you, and got to say, I'm really impressed with the grasp that y'all have on the issues that we're facing. I am here to speak, in addition to our members, on behalf of the Georgia Professional Health Services Association, the Georgia Retired Educators Association. What you know is tragic. The teachers rally to advocate for Georgia Insurance Choices, Professional Association of Georgia Educators, the Georgia Association of Educators, Georgia Association of Educator Retirees, and the Georgia Department of Transportation Employee Association.
What is that?
Probably a duplicated count, but upwards of 150,000 members and an unknown number of covered individuals, perhaps as much as twice that, 300,000 people. It's and we greatly appreciate the committee addressing this critically important issue. And Mr. Chairman, your opening remarks and those that I've heard from you other members are dead on, in our opinion, is describing the issues being faced. Our members are greatly concerned with being trapped in the billing rate disagreements between medical services providers and insurers, which result in outlandishly high, often late bills for services and providers which were thought to be covered by insurance, but turn out, to our members' surprise and dismay, to be out of network. I have submitted to the committee 10 pages of examples which are similar, I'm sure, to examples you already have received and noted, and you have plenty of. And I'm sure that I can provide you many other examples as well. Many of the individuals whose cases we've documented have suffered great financial hardships as well as inconveniences and frustrations in trying to resolve the balanced billing. I personally and my parents have previously been surprised billed, and the chair of Tragic, the teachers rally to advocate for Georgia Insurance Choices, was going to be here to testify to you today. However, he's have to be out of town with his in-laws who have just received a $1,500 balance bill, and to help them resolve that. This phenomenon is so widespread that I'd be surprised to learn that none of this committee's members have experienced it either personally or through a family member. We, and I dare say the other millions of health insurance covered Georgia citizens, beseech you and your General Assembly colleagues to take actions to prevent your constituents from being similarly victimized in the future. Our organizations do not have the expertise nor the experience to become involved in the central issue of how much to reimburse providers for which services. We can only rely on the wisdom and the goodwill of those involved to reach a consensus that all can live with. Regardless of how this plays out, our members, and surely all other Georgia medical services consumers, request legislation that will limit our liability to the in-network provisions of our respective insurance policies. One approach that we've heard today that could help would be to require in-network facilities for various insurers to credential only in-network providers for those insurers to serve the facility's patients. Disclosure, which we've heard, is good, but it won't get the job done in many critical instances. How can you expect an admitted patient to determine whether everyone who steps into their room doors, whether they're in network or not, and then to have the fortitude to reject those who aren't, and not knowing when they're going to be seen by someone who is in network, or maybe they won't be seen. And beyond that, how can they control who reads their scans and x-rays, who does their labs, who administers their anesthesia? There's just no way, disclosed or not, that patients in many instances, if not most instances, can exert that level of control. So again, we most definitely request and will support to our extent possible legislation which will hold harmless consumers from balanced billing. Again, we thank the committee for undertaking this important task, and as I said, we stand ready to assist you in any manner that we can.
Thank you, sir.
And thank you, sir.
I think the state health benefit plans, members, is the document you're talking about. You
That is
provided
correct.
everyone. And, you know, we've been talking about balanced billing, and it is a very serious issue, and we're going to address this. But if those of you will take a look at that document, the very first example you gave, lady received a bill for $283, which is not bad for a balanced bill. And it was dated on May the 6th of 2017. It had to do with the passing of her husband of June the 26th, 2015. That's 2 years.
Yes, sir.
I think we need to be sure that we also address a time frame that these bills have to be submitted, so that, you know, you don't get a shock 2 years later.
Totally agree, and we were very pleased to hear you assert that earlier. And,
So, okay,
and we most definitely support that. Yes, sir.
all right. You know, there are all kind of crazy examples out there, and I know there's a lot of extenuating circumstances that can cause some of this stuff. However, there are certain things that need to be done right, need to be taken care of, and some of these things are exactly what we're talking about. Do anybody on the committee have a question for the presenter? Oh, thank you, sir. We appreciate your support on good. One thing that you had mentioned about that, doctors who have privileges at the hospital should be in the same networks as the hospital. Did I hear that correct?
I said that seems like a reasonable potential approach,
Yeah.
among others.
For those of you in the audience, you know this already. House Bill 71 said that.
Yeah.
But it also said that if a hospital credentialed a doctor, the insurance company had to put them in network. They did not have a choice. The insurance company did not have a choice unless there was cause, such as, you know, the doctor defrauded the Medicaid or something like that. But if the hospital accepted them or gave them credentials, then the insurance company had to accept them. But in the same scenario, the hospital that accepted this provider, the provider had to be in the hospital's networks.
We will support any approach the committee and the General Assembly as a whole believes is going to address the issue, eliminate the balance billing, and have minimal effect on premiums. And beyond that, we leave the approaches to the wisdom of each and every member.
Well, thank you, sir. Appreciate your
Yes, sir.
presentation.
Thank you, sir.
All
And
right.
ma'ams.
Let's see, I know this next guy, Mr. Kirk McGee.
Good morning, Mr. Chairman
Good
and
morning.
members of the committee. My name is Kirk McGee. I am Regional Counsel for Kaiser Foundation Health Plan of Georgia, also known as Kaiser Permanente. We are a delivery system that has a financing mechanism. So we have physicians. In fact, we have the second largest physician group in the state. Our physicians belong to the professional associations around the metro area and in the state. We have relationships with hospitals. We may one day have hospitals here, as we do in California. We run quite a number of them. We employ nurses, lab techs, we have our own labs, and a number of things. So we play on a number of sides in this issue that's very important. And my key point, the 2 points I really wanted to make in here are, one, that you should be lauded for your undertaking of this issue, and it is an issue that needs to be solved. We see it on both sides. The difficulty in trying to figure out what is the best thing to do. I would encourage you, if you do nothing else, to look at the emergency room. Why is that? EMTALA requires hospitals to take you if you are in an emergency situation. They have no choice if they operate an emergency room. State law requires insurers to pay for that care if you go to an emergency room. That is not a marketplace. That's not a choice on either part of the hospitals or with the insurers. And I would say it's not a choice of the physicians working in those facilities. So in that circumstance, an insurance company should not be able to take advantage of the doctor or hospital by just paying anything or nothing. But nor should the hospital or a physician be able to take advantage of a person or even the insurance company who finds themselves in that position because there's no choice. So what should we do? Do we rely on bill charges? No, that doesn't seem fair because, quite frankly, to the questions that we've asked, that's a mystery. And I know it, both sides of it. I know what we do in terms of how we construct prices. It's a very difficult thing. But what we do know and what we can determine is what people accept. What you accept as a hospital, what you accept as a doctor. We can find that information out. And so in that circumstance, I would think that what we want to do is say, we don't want to injure the hospital or doctor. So what have they accepted in the past? What's the average of something? What's a measurement? Is Medicare the right place? And to your point, Representative Hawkins, I could see why you would be troubled by that in some sense, but the real value in that is not the actual price. It's the fact that it is a benchmark. It is something that we could all look at and determine that it's some fair measure of it. When we build contract prices with hospitals and others, we use that not necessarily to set the exact price, but to be able to gauge relatively what's happening everywhere else. And Medicare is a neutral kind of arbiter in that. So what I would push the committee to do is to say, to look at, if you do nothing else, this emergency situation, and look to a price or something that we could use in a fair and balanced way to make sure that physicians, hospitals, doctors, insurers, patients, everybody who touches the system is treated fairly by some objective approach. I also have been instructed, my other point was to come and bring you greetings from our medical group to say they stand with you in this fight. They understand the approach that you were taking in 71 and will engage with you on that approach. It is one of many tools that we might want to look at in another thing, but they wanted me to bring their appreciation for your going down that road. The final thing I will say is just a more general comment, and then I'll sit down. I'm sitting down. I guess I'll walk away. The struggle that we are all facing is one that has been coming since the advent of Medicare and Medicaid, third-party payments. And we are going to a place even now in Congress. We haven't addressed this. We called it the ACA, Obamacare, call it what you will. It was about insurance reform. It really wasn't about health care reform. We haven't tackled the thing. People, I've represented and still work for insurance companies, and it's not always something I bring up at cocktail parties. Or the fact that I'm a lawyer, that's another thing. I'm a lobbyist. I get all sorts of bad things, so I talk about my grandkids. But the truth of the matter is, when I try to talk to people about insurance, and we are vilified. Nobody loves their insurance company. People love their doctors and their dentists and their hospitals, but nobody loves their insurance companies, and because we're seen as this thing. right? That you just take the money and you don't come back and respond. And I can get that. I understand that. But the reality of it is, if you're fixing or trying to fix the insurance companies, you're never going to fix the problem, because that isn't a problem. We are a reflection of cost, the costs that come to us. And so when we approach this issue and every issue, I think we ought to step back and say, what are we really going to do about cost and fairness and cost? And this is ground zero for you to have that discussion. And it ought to be something that is a solution to fairness to everybody involved. And as I said, even on the insurance side, I include doctors as number one in that equation. Thank you very much.
But before you run off, you had talked about addressing the emergency room issue. You know, emergency rooms are a little different in that they are emergencies.
That's right.
Are you saying that maybe setting, I have an issue as far as setting prices, but using a usual and customary rate generated annually by some outside group like the Department of Insurance or something to determine what they would be compensated?
I think that's an approach. If you had a third party or some neutral who could look at what has been accepted by providers and hospitals, that gives you some idea of what is fair and what people. So, for example, if you've negotiated that, if you're willing to take X amount of dollars, and you can do the average of that, that gives you some idea that it may not be exactly what you want, but it's a fair price because people are actually accepting that. So yes, I would support something like that, whether it is some percentage of Medicare, the average contract price, something done by the commissioner, something that the insurance companies are not in control of, nor the providers, but someone who could objectively look at that.
So, but the only way we could ensure that the emergency room docs accept that would be through legislation, mandated, saying that you will accept this and you will not send balance bills.
Absolutely.
Okay, number 19.
After your statement, I don't have a question.
Okay.
I'd rather not ask my question.
No, go ahead. Everything's fair game here.
We've known each other for a long time.
Yes, we have.
I have great respect for you. You really have been in the healthcare arena for a long time, and thank you for all your contributions. With your experience, and we both having gray hair, and looking back the way it was and the way it is now, I think we can agree we have better healthcare as far as all the procedures we can do. I mean, a month or two ago, I was looking at a CBCT for my office, and it's $250,000, and they're not going to pay more than a Panorex, so it sort of limits me in being able to do that. So the technology is part of our problem. I mean, that's running the cost up, and we all realize that. But most of the fees in network Medicare and Medicaid for physicians and providers are set. So if there's no balance billing, they're all paid the same. And I don't know if that's a great solution, because I know some are better than others, you know, and that's just the way life is. Some just take more time. They're not going to be rushed. And I'm one of those old guys, I'm not going to get rushed. I'm not going to see 40 a day.
Right.
You know? So I guess what I'm going to with this is, where do you see a solution? It seems like the more we get into it, the worse it gets.
So I see a couple of things, and I don't disagree with you that the way we price in the healthcare arena is not probably the best thing that we do in this country for healthcare. So, and I'm just going to take one moment to give a little bit of an advertisement. We try to change that at Kaiser. We are not perfect at it, but we are attempting. Our physicians are salaried, so there's not an incentive to sell you more healthcare or use something. We say, give the best healthcare that you can, given where we are. And I think that's what's going to be the answer ultimately, that there are going to be more companies like ours. We can't have a system where I got to punch you in the nose so that I'm successful, you got to kick me in the shin. We have to have a system that says, what are we going to do? How are we going to use the resources that we have for the betterment of the patients? So we need to look for different payment models. We need to reward for quality, and quality has a lot of things. We talked earlier about outcomes. An outcome shouldn't be, do you take a diabetic and get rid of diabetes? Is, have you done the appropriate things for that person? And that should be rewarded. So we're going to have a system. We've seen nascent parts of this. We've seen hospitals and insurers try to come together so they can be one thing. We haven't quite figured it out everywhere. But ultimately, that's going to be the question. In terms of what people get paid, one thing that you do by saying average contract price or some percentage of Medicaid, you give people the incentive to want to contract, and they can cut their own terms. You reserve in the right of a physician, for example, that, okay, if this is my ultimate price for this, maybe my thing is I should be contracting with someone so I can get the volume or get some other benefit from having contracted. I get faster payments, I get maybe a bonus if I call you and I help you get the person in the right facility. So there are ways to think about that. So a contracted price or a price that's objectively paid may be the incentive for the contract. I don't have to force you. Now you want to because it's in your economic interest. And that's one of the reasons I support there being a neutral price to look to.
But you also support independence.
Absolutely.
Some way. The last thing we need is a labor union.
Yeah. You know, back in 1994, I was a part of a fight in the state. We had a constitutional amendment where we alleged that there were unions being pushed on behalf of doctors, and I didn't support that, and I don't. I do believe, and I had this discussion with the chairman, I do believe in independence. I believe in the value of the country and the creativity that someone has and the value they put in to get an education, to become a doctor, and they should be entitled to enjoy that in some form or fashion. However, we also live in a place where we are stuck together as human beings and we get sick, and we need to have a healthy way of doing it. And it's not just one size fits all. It's not just one determination. We have to have considerations for everyone in that system.
It's not about the money. Unfortunately, sometimes we deal with it. People's health.
Yes.
Not be about the money.
It should not be, but we have a saying. So my company is a not-for-profit, but we say no money, no mission. You can't practice your dentistry without having funds, and so that's a realistic concern. We just have to be thoughtful about it.
Mm-hmm. Representative Taylor.
Thank you, Mr. Chairman. Thank you for your presentation, and I was very pleased to see someone bring up something that has bothered me for many years. And with the advent of Medicare, which was very needed, and I get it, but you sort of led the doctors to the feeding trough, and we put blinders on our consumers. We expected someone else to pay the bill. We washed our hands of it. We now are in a position that we have to bring the consumer back in. The Affordable Care Act did that to a degree, and I think a part of these balanced bills are a reflection of what's happening in the industry. So I feel very much that this is, we're a little late in getting here. It's gone on for 3 generations now. Mm-hmm. But I appreciate your help in bringing this to the front, because this is something everybody has to be a part of. We cannot have sides on this. The side has to be on the consumer, the people. We are all going to need health care at some point in time, and we are going to be users of the healthcare system. And what we have right now is broken. So your suggestions and ideas are very welcome. Thank you.
Thank you, Representative Taylor.
Thank you, sir.
Thank you, Mr. Chairman.
Appreciate your comment.
Thank you.
Okay, that's all we have signed up to speak on the bill. Anybody? Yes, ma'am. Come on up. Oh, I can't believe that.
It happened, it's true.
Yeah, what traffic? You know, we got a system here built for 2 million people. What problems do you run into? Considering we got 6 or 8. Yes, ma'am.
I'm Beth Stevens from Georgia Watch. We're a consumer advocacy organization, and I also have some stories that I wanted to share with the.
Okay, if you'll give them.
And so my primary reason for being here today is to share these 17 pages of consumer stories that we've shared with you. And you heard Chuck Freeman also share stories with you from folks on the state health benefit plan. But we are a statewide consumer advocacy organization. We advocate and assist consumers with multiple issues, including access to affordable health care. And medical bill issues were the number one reason that consumers contacted Georgia Watch in 2016. We have a toll-free helpline where consumers call us and ask us questions, and we provide resources to consumers. We've actually just recently produced a resource on medical bills and medical debt for consumers because we've seen that this is such an important issue. And so we've collected these stories also with the help of Consumers Union, which is the foundational arm of Consumer Reports. And they have also done some studies on this issue here in Georgia. We have some principles of things that we definitely would like to see in legislation. And one of those things is notice and disclosure for consumers so that they're not surprised by out-of-network bills. Fair and reasonable method for determining payment of those bills, and sometimes that does include dispute resolution. Whatever that is, we ask that take consumers out of the middle so that they're not a part of that dispute, and so that consumers are protected when they do unknowingly encounter out-of-network providers. The issues that we've seen of consumers incurring bills of hundreds or thousands of dollars when they do have insurance and they do think that insurance is going to cover those costs it's a very unwelcome surprise for consumers, and sometimes it leads to outstanding medical bills that can hurt consumers' credit. And so it concerns us at Georgia Watch as a consumer advocacy organization, and I want to thank this committee for meeting and continuing this conversation. We've provided testimony numerous times on this issue, and we'll continue to do so because we think it's really important that we have these protections in place in Georgia. So thank you very much.
Okay, thank you. You said your most, the calls that you get the most about is on balance billing?
Well, not specifically balance billing, but we have gotten calls from consumers certainly on balance billing, and those are included, many of them, in what we handed to you. We get calls about medical bills in general. Sometimes it's medical debt, sometimes it's a hospital bill and needing to navigate how to get financial assistance, sometimes with medical bills. It's all the gamut of medical billing issues, but that is the number one reason that consumers called us in 2016. We do an analysis every year of what we get calls about, and that was the main reason.
Have those calls been increasing on an annual basis, or when did y'all, do you have a comparison to, like, say, 13, 14, 15, 16, or has it been increasing or remaining the same, or?
We can certainly look back at that and gather that information. I do know that our volume of calls in general increased from 2015 to 2016. I can't speak specifically to the medical debt and billing issues that we've heard calls about, but I can look at that data.
Okay, please do. Okay. Anyone have a question? Okay, very good. Thank you, ma'am.
Thank you very much.
I got a couple of comments I'd like to mention to you, but if you're watching the news and reading the news, you hear a lot of things about the health industry that are disturbing, that are things that if you read them and try to understand them are concerning. And one of those things is single payer. And Ms. Scott, if you'll come up for a minute, then we'll let you make a little short presentation over something else. But single payer, the state of Nevada passed through both houses there the single payer plan. The governor vetoed it, but single payer plan. And their term for describing it was called Medicaid for all. So the moment you're born, you're in that program. California, one house, I think the Senate in California passed it, and waiting on the House to take a look at it. And they call it Medicare for all, or Medi-Cal for all, whatever they call it. And one of the statements they made there, no more insurance companies. because in our case, DCH would tell you what you was gonna be paid, and either accept it or you don't get paid. But, you know, you got California, New York has passed the single payer 3 consecutive years. It hadn't gotten through all the houses in the governor's signature, but I don't think anybody in this room wants a single payer plan, because your doctors then would be compensated probably at the Medicare rate, because that's what so what's out there now the government's paying. You know, if the federal government's paying a rate and you accept that, you know, then why not on the state side? You know, they just copy it. So what I'm wanting to do is to emphasize that we need to get this issue resolved. And, you know, I don't want any outside group, small group trying to sabotage it, because we're gonna solve this issue. And I want to be sure that everyone knows that, you know, the purpose of this is to get the patient out of the mix. You know, they should not be sitting around worrying about how they're gonna pay a $5 or $10 or $50,000 surprise bill. You know, this needs to be resolved between the providers and the insurance companies, not with the patient's payment. And by the way, you know, for those of you who don't know a whole lot about air ambulances, they're federally regulated. They're regulated as an airline, so we have absolutely no control over them. So you need to talk to your congressperson to tell them to get their act together so that we can address that issue. But we want to be sure that, you know, we are in this room together trying to solve this problem. So that's the whole purpose of this study committee. And one of the ways we're going to do it is based on information that the insurance department has agreed to gather for us. And I'm going to let Lindsay Scott, who is the legislative liaison for the insurance commissioner, to tell you about this program and give you some kind of dates as far as once the information is ready.
Thank you, Mr. Chairman and members of the committee. As the chairman stated, in an effort to help address this issue in Georgia, the department did several weeks back issue a data call to all health insurers in the state of Georgia. Data submissions have been received at this time. We're currently reviewing and analyzing that data. We anticipate that some follow-up may be necessary, but do plan to have that analysis completed as soon as possible. In regards to the data that was collected, that information is available on our website at oci.ga.gov/insurers. We will provide the data in aggregate form only, and I will just run through, Mr. Chairman, if you'd like me to,
Please do.
the things that were collected. So we did ask for a minimum contracted amount, so the minimum or lowest contracted payment amount for a given CPT code. We collected we asked for about 150 CPT codes, if I recall correctly. We asked for the maximum contracted amount, the mean contracted amount by claim volume, the median contracted amount by claim volume, the mean contracted amount by contract count, the median contracted amount by contract count, the Medicare rate, the Fair Health medical cost, the number of contracts, and claim volume. So again, that list is available still on our website, and that is the information we requested from all of the carriers.
Thank you. We had a conversation in my office, and this information was requested, and they've been super as far as pulling this information together. And I think it potentially will set the benchmark, so to speak, for how we're going to resolve this issue, because the more data that we have, unbiased data, the better we're going to have pulling together the right payment schedule or whatever we have to do, because, you know, this issue has to be solved. And you know, like I mentioned, we're probably going to have 3 or 4 more meetings between now and January. But, you know, this information should be a tremendous help to us once we, have a chance to look at the aggregate numbers, because it's not going out by insurance company, it's all aggregate data.
And I apologize for not having a specific date, but I do anticipate sometime within the next few weeks, so sometime in the month of July, we will have that report ready.
I've been saying August, so,
So we'll be ahead of that, hopefully.
yeah, so as long as we have it in there, we'll have our next meeting probably once we know about when that data will be, so we'll have a chance that y'all can make your presentation on PowerPoint and everybody can see it and this kind of stuff.
Terrific.
So, that's what we'll plan to do, is probably meet after that data's pulled, and we'll go from there.
Terrific, thank you.
Okay. Thank you, ma'am.
Thank you.
Does anyone else in the audience have anything to say? Okay. Well, I guess you gonna make your next meeting on time? Yes, sir. Okay, all right. Well, I guess the meeting's adjourned, and we'll be sending out notice once we find out for sure when the data, from the Department of Insurance is, together, and we'll see y'all then. Thank you.